It's always interesting when people talk about lifestyle, they always assume it's exercise and diet. Lifestyle medicine, it's a specialty of medicine. It's growing in the States, and it's a board certified specialty in the States where, you take courses and you write an exam for it as well. And there's always continuing learning for it. And it's really about addressing the non-pharmacological treatment of patients especially with cardiometabolic illness, but other illnesses that we're learning as well, like MSK illnesses as well, using the six pillars of lifestyle change, including nutrition, so optimizing whole foods, high fiber nutrition, as I call it, optimizing activity, so physical activity, whether it's exercise or non-exercise activity, sleep management, stress management, promoting healthy, positive social connections, and then avoidance of risky substance use, right?
So, welcome to At the Helm, the podcast series where we explore food not just as fuel, but as a powerful tool in the treatment and prevention of chronic disease. I'm your host, I'm Dr. Charles Helm, At the Helm. I'm a family physician and a paleontologist. Today, I'm actually broadcasting from Saskatchewan on the Canadian prairie from the family farm of my in-laws. They've only been here for 60 plus years on the same farm.
Wow.
So it's a privilege to be calling in from here. But as a family physician and a paleontologist, I'm fascinated by the intersection of our current problems with human health and our ancestors and what diets they evolved to eat and therefore how we're adapted. And that intersection bringing together science, experience, hopefully a bit of common sense to help us navigate the way forward towards better health. And today's guest is Dr. Jasdeep Saluja. He's a respected internal medicine specialist and internist. He's an educator. He's an international thought leader in lifestyle medicine. So he graduated at Queen's in 2009, worked hospital-based internist work in Ontario and British Columbia. And then in 2017, he co-founded Aroga Lifestyle Medicine, which is a clinic that offers a structured, sustainable, and evidence-based approach to improving health through lifestyle change. Now, he holds board certifications with the American Board of Lifestyle Medicine and the American Board of Obesity Medicine. In fact, he serves at the moment on the board of directors of the American Board of Lifestyle Medicine. And his mission is simple. It's to help people reconnect with their own innate strengths and their ability, therefore, not just to survive, but to thrive no matter what stresses they face using lifestyle medicine. And his approach is compassionate, it's practical. We're going to hear all about it today and how he achieves this one day at a time, one choice at a time. Welcome, Dr. Saluja, Jasdeep. I'm so happy you're able to take time from your busy schedule today and your busy practice to spend time with me on At the Helm. A warm welcome.
Awesome. Thank you for that warm welcome, Dr. Helm. Thank you for the introduction and the invite. And I've been looking forward to this conversation with you.
I've been looking forward to it very much for some time. So, can we just start at the beginning? What drew you to medicine in the first place, and then what drew you
Yeah.
to becoming an internist? This is before lifestyle medicine, just the olden days.
So the joke in the family is, well, what the family says is that for as long as they can remember, I grew up saying I wanted to be a doctor. And the joke in the family is that when I was sleeping at night, my dad was whispering it into my ear. And and knowing my dad, potentially there may be some truth to it, right? And but as I was in high school and earlier years, every year just wanted to got more excited about medicine and the opportunity to work with patients and people on actually health and wellness, diving deep into, diagnosing problems, all of that. That seemed like a very exciting venture for myself, right? And it still is to this day. Super excited about working with patients in medicine. And when I finished at Queen's in 2009, I was an internal medicine resident here at UBC in Vancouver. Finished that in 2013, was moved back to Toronto. and was working as a hospital-based internist there, and I loved the work. Um, in 2012, in my last year of residency, my dad ended up having a stroke at the age of 58, and was taken to hospital in Toronto. Had the best care, that you could get at the time. Had a CEA, came out of the hospital feeling like $1 million, no issues, no deficits whatsoever. Put on the best medications, guideline-directed therapy. But nobody talked to him about anything about making potentially some lifestyle changes. And he wasn't like, the basics were covered. He didn't drink any alcohol. He was a non-smoker, well-respected individual in the community. But if you know anything about Punjabi diets, if they're not intentional, they can be quite rich in saturated fats and in high processed carbs. And he was like, in India, he grew up on a farm. To so help support his education, he would work on the farm as well. But in Toronto, he spent his career as an electrical engineer. It was a desk job, so there wasn't much physical activity. And so nobody really paid attention to that. And I have to admit, I didn't pay attention to it either. And in 2015, I was driving him to the hospital again with symptoms of a heart attack, and he had had a heart attack that day. And again, fortunate for this Canadian system, we had amazing care at the hospital. He got his stenting done, sent home. And interesting thing was there wasn't much, and as you know, right, between stroke prevention medications and cardiac medic, there's no difference, right? They probably all we added was Plavix again, right? So there's no more medications to really optimize things at the time, and that's when I started scratching my head and wondering, my dad's still pretty young, at that point he was in his early 60s. His two oldest brothers had passed on with early heart attacks. Um, I was in my early 30s, busy resident, hadn't given much thought to my own lifestyle, right? For the viewers out there, if if there's, those of you in medicine know that sometimes we're not healthy in residency. So I had gained weight during that time. I had just gotten married, and so we had done my insurance blood work, and I found that my cholesterol was a little bit on the higher side. So I just started thinking about life, right? You started thinking, okay, is this all destiny? Am I going to be going the same route? And so that's actually what got me starting to look at diet and lifestyle changes. And so initially found the work of Dr. Dean Ornish, who's a pioneer in the lifestyle medicine field. In 1990, published an article in the Lancet journal for showing significant outcomes in cardiac patients, where when you take patients with known heart disease and put them through a healthy lifestyle change program, significant clinical outcomes, but also, radiographic outcomes showing, artery diameters increasing after post intervention. So I was like, those are very impressive papers that he had written, Dr. Esselstyn, other lifestyle medicine pioneers, and just started looking at these changes and saying, okay, we could probably do these changes in my own family. And knowing that if I wanted to get my dad on board, I'd have to do it myself as well. And it was important for me too. So we made a huge change in our family. My wife took a course on whole foods, plant-based cooking, 6 months and whatnot. And over the course of a year, we made some significant changes, started working out, and just feeling a lot better. I used to be tired all the time, and getting, improving your energy levels, having more zest, and just wanting to get more in life. And then during that time, when we're making these changes in our lifestyle, I got an opportunity to come to Victoria to work. Dr. Jesse Parchak had hired me out to the hospital, and so I started working for Island Health at the time, and was working in the division as a busy job. But with the opportunity at Victoria Hospital was that in addition to the inpatient work we were doing, we also got an opportunity to work in the UMAC, the Urgent Medical Assessment Clinic, and we get a lot of cardiac assessments out from outpatient world, like chest pain consults. And so because I was making these lifestyle changes myself in our family, I had started seeing these patients with chest pains, put them through the treadmill stress test, didn't find that they didn't have any, significant amounts of cardiac disease, but they had risk factors, and started talking to patients about, your A1C is elevated, your cholesterol levels are elevated. We should probably put you on medication. If you want to, delay medication for about, 3 months, work on some dietary and lifestyle changes, we can do that as well, bring you back and get your labs measured, and then see what we need to add in, right? And about half the patients were saying, "Yeah, I would do this. I would take you up on that." And started doing that for about 6 months, and then 6 months go by, and Jesse Porchuk, who is one of our co-founders at Aroga, but he was also the head of the division in internal medicine. One day we went out for lunch, and he started telling me about that for the last 6 months he's been working with patients in the UMAC on lifestyle changes to help with their diabetes and whatnot. And we couldn't believe it that we were working in the same clinic, door down from each other, and we'd never spoken to each other about this. I initially I thought he found out that Jazz is, I thought he maybe heard that Jazz is giving patients dietary advice, and he's just having some fun with me. But it turns out him and his wife Nicole, who's also a family doctor and a team member at Aroga, were making their own lifestyle changes at home, and kind of had gone on their own lifestyle journey. And so that lunch meeting became the genesis of Aroga. And because at that point we started recognizing that as two physicians, as internal medicine doctors, we learned like the evidence, we can learn the pathophysiology of disease, we know the pathophysiology of insulin resistance to the best of our abilities. We can communicate that with patients, but patients just they don't just need a doctor, they need team members, right? Because patients, if you're truly committed to honoring the current lifestyle that they have and how to take from point A to point B, we got to see what is contributing to that, right? And some patients, they need help with a dietitian. Some patients might need help of an exercise physiologist to come onto the scene. If patients have a lot of trauma, they might need emotional wellness support, right? So truly team-based care is what makes lifestyle medicine from a theoretical and academic pursuit and intellectual pursuit to actually a practical implementation where we can actually change lives on large scale, right? And so we initially talked about, approaching the hospital for developing an outpatient program, and we quickly realized that the health authority, they're inundated with so many demands on the health authority. You got residential care, you got acute care, and those numbers don't seem to be coming down. And so we realized this was something that we'd have to, kind of do on our own. So that's why we formed Aroga. At the time, it was called Revive Lifestyle Medicine. It was a small outfit. We rented space from an underutilized walk-in clinic at the back of a grocery store in Langford, and just let our local family doctors know that we're still doing internal medicine, but we're doing it from the foundation of lifestyle change. We hired a dietitian out right away, and kind of had her participate in our consults right off the bat. And so that's how we got started in the lifestyle medicine journey. It's been a whirlwind journey of 8 years, and we've learned a lot and continuing to learn a lot. It's an everyday learning experience.
The interesting thing to me is that, and I find it with so many of my colleagues and patients, there's something in the family or there's a personal experience that ignites the whole thing. And it really seems that for you, the turning point or the epiphany was seeing your dad go through this not once but twice and realizing it can be different and I'm going to try and make it different. That's what I think you're
Yeah.
telling me.
Yeah, that's exactly what it is. And it's true, like a lot of lifestyle physicians that I have met, since getting on this journey, meeting at conferences, other Canadian doctors that are doing this, it does come from personal experience a lot of the time. It's an epiphany. Some doctors, I've met colleagues who have found themselves at burnout, and then figuring out why are they getting burnt out, and that's causing the questioning, right? Um, but the interesting thing is, the encouraging thing is that there's a lot of residency programs now, even especially in the States, that are now talking about lifestyle medicine, right? And they actually they have residency medicine, like so they have. There's through the ABLM and partnership with the ACLM, there's a thing called the Lifestyle Medicine Residency Curriculum, and it's being implemented in quite a few of the family medicine residencies, internal medicine residencies, and physiatry residencies in the States. And Dr. Caroline Room, last name spelled Rheume, she's a family physician in Ontario, but she also has work with Quebec. She was helping one of the universities in Quebec actually implement one of the first lifestyle medicine residency curriculums for a residency program in Canada. And so the nice thing now is like when colleagues are reaching out, oftentimes they're actually residents who are just finishing up residency who are already into this, which is pretty exciting.
That's wonderful news, and maybe we've got a ways to go here in the West, but it's very encouraging that those things are happening elsewhere. Very, very encouraging. Can you just let me know what Aroga actually means? What
Yeah.
is it stand for? Is it an acronym, or what does it mean?
Yeah, no, for sure. So when we first started, we needed a name and we started with Revive because we felt that described what we were trying to do, and everyone gets that. But then as we looked around, there was actually other companies that had the name Revive in it, so we actually had to make a change if we wanted to go outside of British Columbia and whatnot. And so we kind of went on a journey of finding out what would help us um, describe what our mission is, what's like, what we call it, some people call it your massive transformational purpose, right? Your MTP. And Aroga actually comes from Sanskrit. And so in Sanskrit, rog means disease, right? And oftentimes, anytime you have a root word in Sanskrit and you have like attached to it at the front of it, it means to get beyond or without, right? And so Aroga is our sort of MTP or massive transportational purpose is to restore wellness in the communities that we serve and restore ease and moving from dis-ease to actually just restoring ease.
Yes, yeah. No, that's great. So now I understand
Yeah.
what the meaning of Aroga is. Can you tell me just a little bit? It's been 8 years, but your current clinic size, location, and how many people pass through
Yeah.
it annually?
Yeah. So we've served over 70,000 referrals to our clinic, right? To the organization since we started in 2017. Currently in Victoria, we've got a team of six internal medicine doctors, an endocrinologist, a pediatrician, psychiatrist, sleep specialist, three family doctors, nurse practitioner, an RN. We have three dietitians on team. We have three clinical counselors in Victoria um, and three so I think dietitians, and actually we just brought on a physiatrist as well, an exercise specialist. And so that forms bulk of the clinical team in Victoria. And we've got a huge administrative team, with our clinical managers and directors and our patient care coordinators who are pivotal as anyone in healthcare really knows. Like they do the heavy lifting of making sure that, the appointments are being booked in, patients are excited about, the care that they're receiving. So we've got that team in Victoria. We started our clinic in Vancouver a couple of years ago. So we've got a medical director in Vancouver, Dr. Stephen Sharp. He's a family doctor. We have a second family doctor that just joined the team in Vancouver. We have an internist who works with us part-time, and we have another internal medicine doctor, Dr. Eden English, who's currently moving to work with us in Vancouver from Denver. Um, and we're bringing on another internal medicine doctor there. And we have a full-time psychiatrist working out of our Vancouver office as well, a clinical counselor and a dietitian. And then a couple of years ago, we started our location in Brampton, Ontario. So it's just in the Greater Toronto area. We've got three internists that are currently working there, two family doctors that work with us, a dietitian, and a clinical counseling team. We also have a physiotherapist that's working part-time out of that office as well. Um, and yeah, so that's sort of the clinical teams that we have currently. Brampton's exciting. We have been signed up to be one of the clinical teaching sites for the new medical school that opened up in Brampton at Toronto Metropolitan University. So we'll be one of we'll be a part of the clinical rotations for students that are going through, which will be amazing because again, it's another opportunity to expose learners to lifestyle medicine early in their career, and they can what the nice thing is that they could go and do any career. They could be in anesthesiology and pathology and surgery, but if they've seen the power of lifestyle medicine, that'll carry on through with them.
Yeah, no, that's astonishing that within 8 years you've managed to achieve all that. So look, I'm a rural doc. In a remote community. Uh, what you've got is incredible. It is urban based. Obviously, that's where the majority of the patients live. But so for patients, say in rural British Columbia, for example, can
Yeah.
they access you virtually, or does it need to be face to face?
No, we started doing virtual care actually quite early on, even before the pandemic happened. Our co-founder Jesse Parchak actually was one of the co-founders of Medio, and so if you know about Medio, it was one of the first platforms for virtual care in Western Canada. And so he'd always been on this journey of like we need to have, the power of virtual care is reaching communities that don't always get access to care in person. And so we service all of British Columbia, right, through referrals. And so mostly like a lot of our referrals are for like, obesity, type 2 diabetes, fatty liver infiltration, and through virtual care and connecting with their local family doctors, we can provide most of the care virtually as well. And even in Ontario, our patients do come to the Brampton Clinic in person, but they're also being seen virtually as well.
Right. No, that's very encouraging. So you're covering the whole works.
We're trying.
Um, can
It's
we just
never.
change tack?
Yeah.
Right. Can we just change tack? I would like to know, my understanding is that lifestyle medicine, there are these kind of six basic pillars. Just so our listeners understand really what we're talking about, can you take me on a whirlwind tour of the six
Yeah.
pillars?
Yeah, no, for sure. It's always interesting when people talk about lifestyle, they always assume it's exercise and diet. Those are the most common things. So lifestyle medicine, it's a specialty of medicine. It's growing in the States, and it's a board certified specialty in the States where you take courses and you write an exam for it as well. And there's always continuing learning for it. And it's really about addressing uh, the pharmacological treatment of patients especially with cardiometabolic illness, but other illnesses that we're learning as well, like MSK illnesses as well, using the six pillars of lifestyle change, including nutrition, so optimizing whole foods, high fiber nutrition, as I call it, making sure that you're getting optimizing activity, so physical activity, whether it's exercise or non-exercise activity, sleep management, stress management, promoting healthy, positive social connections, and then avoidance of risky substance use, right? And so those are the six pillars of lifestyle change. More recently, there's within the lifestyle medicine world, because we're always learning and evolving. There's a discussion of not really a seventh pillar of lifestyle, but like an underlying sort of foundation of these six pillars is what we're talking more about in the lifestyle world, about meaning and purpose, right? So having a sense of meaning, having a sense of purpose, positive psychology, having like, so that sort of is the foundation, and then these pillars kind of stack on top of that. Um, because we're finding that there's so much more research that's going on in terms of like behavior change connected to having meaning and purpose, even spirituality in someone's life, to actual health outcomes, right?
Yeah. So, of those pillars, which would you say, either for you or for your patients, which is the most challenging or the hardest for them to address of the six pillars?
Yeah, no, I guess that's a great question. It's an interesting thing. Um, you know, over time, so I used to say, as I've done lifestyle medicine, that you come in through one way. So I came in through diet sort of pillar, right? And I got super excited about it because the cardiac outcomes and whatnot. And then as you continue working and you see patients, uh, I think it's really, they're all sort of connected, right? So one connects with another, right? And so you go, okay, someone's having a difficult time making a dietary change. Why are they having that change, right? And as you continue following that, we do live in a time that's quite stressful, right? So people have a lot of stress, people have a lot of isolation. Sleep has been ignored for a long time for in our society. Other than diagnosing with sleep apnea, there's not always a lot of resources for helping patients with insomnia, or even, you know, uh, talking about how beneficial and how much it's actually related to insulin resistance and all these things. So sleep is a big deal. And when you get even past that, I really do think meaning and purpose is a big deal, right? And so I oftentimes will ask my patients, when they're first referred to me, let's say for diabetes management or weight management, I ask them, why are you here today? Or, why are we here virtually? Why are we here in person? And they might say, Dr. Helm referred me. Okay. I go, well, why did you make the appointment? Right. because I thought it'd be good. Why did you feel like, why do you want, like, and they're like, they'll say, I want to help with my diabetes or my weight management. Why do you want to do this, right? And I keep asking these why questions to kind of find out why they want to live and what pushes it, what propels them. And then I really try to focus on, like, actually that's why you're here. Like, this other stuff is just a part of your, it's part of, like, your journey, and it happens to be a part of, like, your current, the current things that may be affecting your actual real why. But that's why you're actually here, right? And so I think I want to, if the one takeaway really is, from a lifestyle perspective, is really just find out why your parent, what makes your patients excited about life, and are they excited about life right now? Why aren't they excited about life, right? And so if we can work backwards from there, it actually makes lifestyle changes and the lifestyle medicine journey that much more, I wouldn't say easier, because there's challenges along the way that we have to, but it makes it way more sustainable, and you can sustain the waves and the rocks and the valley up and down of life that life throws at you, if you can always connect it to why are we doing this.
Yeah, and as you probably know, I'm with IPTN, which is the Institute for Personalized
Yeah.
Therapeutic Nutrition. So we come at this predominantly, I guess, from the diet nutrition perspective. But you're not the first guest that has said that. So many guests have said this, the same thing, that yes, the diet and the nutrition are incredibly important. Maybe they are the cornerstone, but all these other things are so
Yeah.
important as well, and they have to interrelate to get us to the final outcome, which is the desired outcome of someone that's healthier and happier and living longer in a healthy, happy way.
Yeah, no, for sure. Like, diet is super. I mean, we do know, someone has insulin resistance, someone has weight management, they have non-alcoholic fatty liver disease. They're going to have to make some dietary changes if they want to address these issues through lifestyle change, or if they even want to get, having a chance at remission, right? So these are going to have to happen. Um, I've seen, because I guess the value of being in experience in having done this clinically for 8 years, right, is that we see patients, make these changes, and I've had patients go from an A1C of 12 to 6 in 3 months, right? I had a patient come off of 200 units of insulin, right? And you see all this, and early days they get excited. I'm like, oh, that's a win. We're done. We've won here. And then you see that patient again, a year down the line, right? Because they've been re-referred, and they've gone, they've had this, they're right back into where they are, right? So it's not that the dietary changes didn't work, they didn't sustain, right? And so then that starts asking questions. So when you know that the patient knows how to do something, they have the resources to do something, and if they're not able to sustain it, then there's something that we are not addressing, right? Uh,
Yeah.
and why I had once had a colleague say that, people don't change long term, right? And I I would say I would say that isn't true, right? I think everybody has the potential to make a long-term sustained improvement, or optimization in their lifestyle. It's really on us, if we really want to be of service to our community and to service to the patient, is to find out what needs to be addressed, right? And then help them
Yeah.
address that, right? And so some patients, if they've had PTSD, or they have early childhood trauma, or all these, there's other things that are in their lives that are stressing them out. If there's financial difficulties that are stressing them out, um, we can't talk about certain things without addressing certain things. And that's where we have to be, always going into every consultation of how can I be of service to this patient today in this moment?
Yeah. Yeah. And what you're saying is nothing is an island unto itself. Everything is connected.
Yeah.
Just for our listeners, I'm just going to mention that an HbA1c is what we as physicians often use to track the progress or improvement or deterioration in type 2 diabetes or type 1 diabetes. But an HbA1c of 12 is extremely high, and an HbA1c of 6 is pretty darn good.
Yeah.
And if that person's on no medications, that if it's persistent, that would be classified as remission. And what you're saying, Jasdeep, is that we do sometimes see people in that situation, and we all get excited, and oh dear, a few months later they're kind of heading back to where they came from, and then you've got to bring in all these other things. But can you just give me a couple of examples of the transformations that you've seen. So maybe not the case where someone improves
Yeah,
and then regresses back,
no,
but
no, for sure.
a little bit more the long-term transformations. Just one or two examples.
Yeah. So I had this one patient that I've worked with for a while. When I saw her in 2019, she had been actually referred to our clinic by her gynecologist, right? And the reason why she had it referred by a gynecologist because she didn't have a family doctor. So she was having gynecological symptoms, complaints of bleeding. She had symptoms for a while, but then she had gone to an urgent care clinic, and at that one urgent care clinic visit, after I guess what blood work was done, she was diagnosed with type 2 diabetes. She was diagnosed with high cholesterol, high blood pressure, and she was put on a statin, metformin, and an ACE inhibitor on the so on right in that same visit. So blood pressure medication, cholesterol medication, diabetes medication, sent on her way, but she didn't have a family doctor, and so this speaks to the primary care uh, crisis we have in British Columbia, right? And but she had gotten a referral to a gynecologist, and the gynecologist saw her and assessed her and said, we're likely needing to do a hysterectomy here. But before we'll do that for the gynecological complaints, but you have these metabolic concerns now. Let me refer you to Aroga, and you can, be seen by them. So that's how ended up being seen by us. And luckily, we had just brought on a new family doctor at the clinic, so we were able to connect her with a family doctor. So her primary care is at Aroga, and her specialty care happens here as well. But we were able to see her, saw her in consultation, got her plugged in with the dietitian part of things, right? So saw her with the nutritionist. So I saw her in April, and by September she was offered diabetes medications as well as her cholesterol medications. And then by December she was done, and she was offered high blood pressure medication. The following In the following 5 months from there, she had previously been diagnosed with obstructive sleep apnea, and she was on CPAP machine. So she stopped using her CPAP machine as well. And then she ended up actually taking a Whole Foods nutrition course as well. So she actually teaches other people how to eat now. And it was really fun because we actually, at Aroga, especially pre-pandemic, we used to try to do like group hikes with our patients. Once, every 5, 6 months, we'd just go up Mount Doug or some type of activity. And so we'd organize one of these hikes, and it was literally 1 week after hysterectomy, and she showed up, and and she felt so good because she had lost enough weight. She her you know her she didn't really have significant amounts of inflammation, and so her recovery from surgery was very quick and very easy. And she showed up at the hike, and when I saw her, I was like, "Oh my God, you're here!" Like, I thought you'd be resting. And she's like, "Yeah, my mom said like you shouldn't be going, right?" And she's like, "Well, my family doctor's gonna be there, my internist is gonna be there, my dietitian's gonna, I'm taken care of, right?" But it's just, again, like it went from not only was the medical conditions put to rest, there was also a lot of excitement. And I've actually presented her case at conferences in the past, and I've asked her for permissions, about can I present your story, and she said, and she's always like she's such a giving person. She's very excited about her story being shared to help others. And when I was talking to her one day about her story, she said, "What are you going to share?" And I said, "Oh, I'm going to talk about your medical outcomes, your medical changes." She's like, "Yeah, that's the boring stuff, right?" And I was like, "What do you mean?" Right? I was like, and she goes, "Well," she goes, "You haven't mentioned the biggest impact." She goes, we went from a family where we were actually depressed, and we went to work every day. We came home, we heated a meal in the microwave for ourselves and our kids, had a couple of beers, watched TV, went to sleep, and next morning we repeated our life. We did the same thing. We were in a rut. We weren't communicating with each other. We we weren't happy people." And from there, we've gone to a family that, routinely rides our bikes, 20 to 40 kilometers each week. We actually cook meals together. We have great conversations. We've connected as a family again. And so the real transformation of lifestyle medicine again isn't the fact, the diabetes and all that helps, right? But it's going from people who are simply surviving to actually people who are thriving in from an emotional standpoint, from a physical standpoint, from a spiritual standpoint, and just connecting again, right? And so sometimes in medicine, I that experience taught me quite a bit, because I was like, I was as the doctor, as an internist, and as a lifestyle medicine specialist, I'm constantly looking at, trying to prove that LM lifestyle medicine works, and these are the outcomes that we can go chasing. But our community members and our patients, they see other outcomes that we don't necessarily always capture in the research world, right? We don't capture it. We're not looking for it sometimes. And that's why I think I'm actually super glad that, more and more research is actually having patient partners at the front, at the outset, to actually even determine what outcomes should be measured, right? Another part of that little story that, that again was humbling, but teaching me a bunch. It was like in Aroga, all of our offices have whiteboards in them. And so I do a lot of drawing out. I used to do a lot of insulin resistance, drawing the pathways out and showing here's your liver, your muscle cells, and your pancreas, and the fat in the liver and the muscle cells, causes the dysfunction of the insulin receptor, and your pancreas is having to throw out a whole bunch more keys, and I call them the insulin the keys, and having to go into lock and do this whole thing. And when I asked her about her story, she actually shared with me a 40-page journal that she'd written about her journey with Aroga. And so I was actually excited to read through it and be like, okay, well, she'll probably talk about, when I did this. And she does mention it. And she mentioned it. And she's like, yeah, I saw Dr. Saluja for the first conversation. He did a whole bunch of stuff on the board. And she goes, well, what I really took away from that wasn't the explanation as much as the fact that he cared, right? And so it was humbling to me that I thought I was doing a good job of explaining the science. So apparently I'm not, but I am. But the reassuring thing is that I am connecting with them, and and the patients get, they take away. So it's always interesting to get feedback from your patients. What are you actually taking away from our visits, and what is actually making the impact? Like, what are you hearing that's making the impact, right? Like, I know if you probably know Brendan Byrne, right, at Lifestyle RX. So they're doing amazing work. And so sometimes every now and then we'll have patients that are referred to us as well as to Lifestyle RX, right? And I had a patient, I'd been working with him for a year or two, and we hadn't made a lot of headway, right? Hadn't made a lot of headway from a lifestyle change perspective. And then he comes back one day and he's like made these changes, and he's like, I'm like, dude, you finally made like the changes that we're talking about. And he's like, yeah. And he's like, oh, I got referred to RX, Lifestyle RX. I'm like, oh, that's great. What did you learn? And he's like, oh, it's the same thing you said. He's like, so I'm like, so then what happened today? He's like, well, they put this image up, and there's like this block of butter in the liver. And he's like, that image just did it for me. Right. I was like, okay. I was like, it's just interesting, right? Like, you don't know what someone needs, right? And that's why it's fun to have, a lot of people, out there. And I think the more people we can train on lifestyle medicine as healthcare providers, and they bring their own personalities, their creativity, and how they communicate with patients, that's way more options for patients. Um, if someone doesn't get it through speaking to person A, but they get it through speaking to person B, that's all that matters, that they get it, right? Yeah.
Yeah, one of our previous guests, an endocrinologist and a patient, we had them together on the podcast, and the patient was pretty darn sick by the time she got seen by this endocrinologist. But what she remembers is the endocrinologist said to her two four-word phrases. And the first one, it's not your fault. And the
Yeah.
second one was, I can help you. And that's
And
what she remembers, you know. And so when we say that sort of thing to our patients, it could just be in one ear, out the other, but every now and then it just
yeah,
sticks them. And that's the thing which eventually encourages people to stick with the changes. And
yeah,
and so that's a really inspiring transformational story that you shared with us. And it seems as if sometimes if you do enough work on enough of those pillars, then you kind of get a critical mass, and then it's
yeah.
unstoppable. And that's what I don't know. I guess what we hope for, and often in that situation, you just find, yeah, people no longer need that prescription for the antidepressant or the anti-anxiety
Well,
agent because you just don't need them anymore.
yeah, well, that's the other thing about having, the six pillars, right? And so sometimes when you start with dietary and exercise interventions, and people do really well, uh, they sometimes the eating of processed foods is actually masking, or is masking some of the other underlying issues from an emotional wellness perspective. And so sometimes when people actually start feeling better from a physical perspective, they actually have more space in their minds and hearts to actually feel the emotions that they may have been suppressing, right? And and if they're feeling those emotions, they can be raw, And that's when, it's a slippery slope at that point as well. So that's why if you have that team-based care saying, okay, do you need a counselor at this moment in time, or do you need someone to talk to about this? Mindfulness, meditation, any type of, right? So those other pillars come into play as you sort of are almost like you're taking care of certain issues, but then it's like the onion, right? So you're peeling back layers, right? And different
Yeah.
layers show up, and that's the beauty of team-based care is like you can do team-based care by because if as certain layers show up, you start to implement and tag in more team players,
Right.
right?
So I'd,
And
I'd like to I'd like to ask you because there seems to be an assumption that if you're practicing um, lifestyle medicine, it's implicit in that is that you've got to be vegetarian, you've got to be vegan. So no, I'm from IPTN,
yeah,
and our approach is to say, well, it really doesn't matter if you're vegetarian or vegan or at the other end of the spectrum, carnivore, ketogenic diet, Mediterranean diet, paleo diet. Doesn't matter. If it works for you, that's
yeah.
great, but we want you to be healthy. We want you to prioritize protein. We want you to avoid the processed foods and so on. So to IPTN, it doesn't matter specifically which diet you're on. It's more the principles that are important. So do you have any thoughts on that? In other words, if one is coming to Aroga, is one expected
Yeah.
to eschew animal foods or is it okay?
Oh, yeah. So it's a great question. So it all kind of goes back to from where I got into this from, right? I got into it from a cardiac standpoint, from heart health issues, right? And so in from a heart health issue for a part, if you have coronary disease, there is good evidence to suggest that, eating whole foods, high fiber, high water, so whole foods, plant-based, does really help. And it actually has helped it's what, made the biggest difference in terms of like lowering my cholesterol. Like my cholesterol got cut by 60%, right? With dietary changes, right? And we do know like from a portfolio diet study at University of Toronto, if you're trying to lower cholesterol, portfolio diet can help, decrease LDL cholesterol by on average by about 30%, right? When it comes to insulin resistance, again, learn it again. This way, lifestyle medicine is all about learning and evolving, right? So you look at the evidence for insulin resistance and weight management, uh, and if it all depends on, I believe in now personalizing the recommendation as much as possible, right? And so we've actually really focused. That's why I myself don't even use the words keto or this or low carb or high carb. I don't use the words plant-based as much at all. I talk about whole foods first and foremost because I know Sean quite well. We've actually, really connected at IPTN with him. Me and him connected over the years. And so the approach, I think the general approach is pretty similar in all the diets and all the healthy eating, right? The healthy eating pattern is really whether or not you do keto or vegan or anything, I can, with the help of a dietitian, I can make each of those diets really healthy and I can make each of those diets very unhealthy, right?
Yes.
And so this is why I'm not really big on asking patients to follow any type of diet. Really, it's about what we try to say what are you currently doing? Is there an opportunity in your current dietary pattern to increase the proportion of whole foods, decrease the proportion of highly refined and processed foods, right? Is there opportunity to increase the amount of water on the plate, especially for weight management, right? So water on the plate really is foods that are basically high in volume and low in caloric density, right? Is there an opportunity to increase more of those foods? And then is there an opportunity to increase some more fiber on the plate, right? In whole food form, right? That's how I approach things. And then again, you're gonna have patients who have celiac disease, you have patients who have IBS, you have different sort of issues. Again, in addition to insulin resistance, they may be having, had a TIA or something like that. So I'm really big on personalizing the recommendations. A, for what the conditions that the patient has, B, what's going to be enjoyable and sustainable for them. So if someone does a ketogenic diet and they've done amazing and it's not sustainable, that sucks. If they do a plant-based diet and it's amazing and it's working really well and it's not sustainable, that sucks, right? So I really do think that the optimal diet is some combination. It's a meeting point of here's some of the changes that have evidence for them that they're going to help you. Here's where you're willing to do things, and here's where you like to do it, and here's where your opportunity for doing some learning is, right? So that's where I kind of go from. The second reason why I don't use any of the labels anymore is that I find that in a world where we're constantly being told that we have to do better and we have to do, the self-acceptance and self-compassion, kindness and love is a big deal. And I see it in my patients all the time, especially when patients who've been struggling with weight management, they've been judged a lot, right? And I always want to make sure that lifestyle medicine, the field of lifestyle medicine is a no judgment field. Okay. This is not like like you said, like one of your previous guests said, it's not your fault, right? This is something that needs to be reiterated time and time again. And so what I found over the years of practicing is that even if I said plant forward, for example, or if we said low carb, or we said like, any type of label, it all of a sudden creates a standard for by which the patient starts to measure themselves by again, right? And so what I would see is like I get patients coming in their follow-ups and saying, I'd be like, hey, how'd the last 3 months go? And they're like, oh, it was amazing, but I fell off during Christmas. I fell off during this. I had a birthday here and I fell off and I fell off and and I just got really tired of hearing this negative self-talk because even when you say, oh, I cheated, like I never even like saying those cheat days or anything like that. I say, I tell patients that I grew up in Jane and Finch in Toronto. I don't know if you know anything about Jane and Finch. It's not a high, it was a one-bedroom apartment with my mom, dad, and my sister. It was lower income, socioeconomic neighborhood. I knew that I wanted to work hard. I wanted to be a physician, and I had certain ambitions for my life. And so I had friends who had similar ambitions. So we hung out all the time together, right? Because we knew that by working together, by influencing each other, we would be able to reach the goals that we had, right? Where I had other friends who had vastly different ideas of how they wanted their lives to end up. It didn't diminish them as human beings, and they were just as lovely and they were just as amazing people, but we had different goals. So with them, I would hang out with them once in a while. I'd have a party with them once in a while. So there were my friends that I hung out every now and then with, and then my friends that I hang out every day with. And so I call all foods your friends. So they're foods that, depending on the goals that you set for yourself, it's going to be beneficial to hang out with them more regularly. And then there's going to be other foods that you can party with every now and then, and that party every now and then is more than fine and it's okay. And we don't need to talk about it as falling off the wagon or cheating or this and that. It's just actually a part of your life, right? And so I'm I'm big on like self-compassion and kindness. And I think if we work from there, um, any dietary change actually becomes a little bit easier to make, and we don't need to go 0 to 100. The other thing I've learned with dietary changes, for example, I had to go fully plant-based to help with my cholesterol, right? But I've had patients who've done like not who've just added more, plant sources of protein, like or more oatmeal in their diet, or more high fiber, and cut down on some of the saturated fats. But it's been maybe like 30 to 40% sort of change, and they've gotten 100% of the results. So just like we have genetic variability to that changes our exposure to toxins, or our exposure to processed foods and refined foods and all that, and turns we have different percentages likelihood of developing disease. We also, I think, what I'm learning is that we actually have genetic predisposition to likelihood of how much of an intervention dose we actually require. Not everybody requires the same dose, right, to get the same benefit, right? And so I think that's where you have to be. This is why, like I always say to anyone that's talking about lifestyle medicine, I always say don't make this an intellectual exercise or an academic pursuit. Go and practice it in clinic, because when you work with patients, you learn every day from them, right? And teach us
Can
more
I
than
can I just follow
textbooks.
up with you? Yeah, you've mentioned the genetic element, and so one of our previous guests is an endocrinologist from India.
Yeah,
She's vegetarian, and the great majority of her clientele is vegetarian. And she's trying to get people into type 2 remission from type 2 diabetes. And
yeah,
she's saying the first thing she had to do, just about, so many of her patients were protein deficient, and she first had to correct their protein deficiency, and then she could work on
yeah.
the type 2 lifestyle issues. Now, I'm just wondering, you mentioned your dad, a Punjabi diet, etc. Do we see anything similar in
Yeah,
Vancouver with the high South Asian population,
yeah.
etc.?
Yeah, we do see like protein the protein deficiency, I think, comes what I see is protein deficiency based on what foods are actually crowding everything else out on the plate, right? And so we grew up in a vegetarian household, but we had lots of like fried foods. We had lots of, it was a lot of butter and all of that, but there's a lot of prontas, there's a lot of roti, a lot of processed carbohydrates, right? And so when it comes to the South Asian population, I really do think it is a matter of, evolutionary wise, this is traditionally South Asians have an agrarian population, right? So it's a lot of agriculture, right? And so when you're eating roti in the morning for breakfast or paratha in the morning, that is a powerful energy bomb that you get in the morning, right? And it will last you eat that in the morning first thing, and you're out in the fields 14 hours and you're working the fields with, older equipment, right? You're going to work off all those calories. It's going to be, and you're actually, your body's fueled for the day, right? Um, the problem is now in, Indian society, South Asian society has gone through a big transition in terms of like how much field work are you doing? How much, physical work are you doing? And so even though there's foods that are very traditional and they're honored and they're loved, um, we're not living the same traditional life. And so I think there just needs to be an acknowledgement of, what do we actually need? And so when I talk to South Asian patients of mine or family and friends, this is what I talk about. I said, if we can live the traditional life that our ancestors lived, then let's eat the traditional ancestral foods because our bodies are made for, like they know what to do. Like they know what to do with those high processed carbs. If that's not the case, that's not the life we're living right now, then that's when we have to start making these changes, right? And so even now, like I was just a couple of days ago, I was actually talking to my dad. I'm like, he had come back from a trip and whatnot. So he's doing really well, by the way. He's like in his mid 70s and he's rocking life. But I was like, I was like, Dad, in your mid 70s, I'm like, I think we need to like really focus on you making sure you're getting more protein, right?
Yeah.
Right. So I was like, so I've got like, so I've tracked my protein for a while. Actually, I don't track it anymore now. I used to track it because I working with my trainer, and my trainer had the same concern about my protein intake with being on a plant-based diet, right? But with my plant-based diet, I was getting about 140 grams of protein a day easily, right? And then so we've just been able to like, structure all of my meals are actually around what's the protein source, right?
Yeah.
Even on a
Okay.
plant-based way of doing that, right? And so, but you're right. There's protein deficiency. I also find there's a lot of fiber deficiency, right? And that's a big deal as well, especially when patients are trying to lose weight. We talk about, with the GLP-1 receptor agonists that I use them for weight management. But there's a cost issue, there's a cost concern for patients, and so we talk about, okay, are there other ways to, you know, optimize GLP-1 levels in your body, and a high fiber diet is one way of helping with that as well, right? And so
And so your major protein source would be?
my major protein source, like my
Yeah.
own consumption,
Yeah.
so it's all legumes, right? So lentils, beans,
Yes.
and I do a lot of tofu, do a lot of tempeh, right?
Yeah. Yeah.
That's
Yeah.
my
No,
major
sure.
source.
That's what I thought. Yeah. But can I, just before we wrap up,
Yeah.
Jasdeep, can I just ask you one question, and that is about our indigenous population in British Columbia? Because if we look at the statistics, the rates, the incidence of type 2 diabetes in indigenous communities is substantially higher than in
Yeah,
non-indigenous communities. And what's behind that? How can we address that? I just love your insights on
yeah,
that, please.
yeah. It's good. I think the best person to answer it in more fully in a wholesome way is a member of the community, right? As a member of the indigenous community, I think we need to, that'd be a great episode, actually, a great discussion. But from what I've seen, like the patients that I've been working with, uh, there is a lack of access to healthy, fresh foods, right? There's a lack of access to fresh foods. It's really easy to have the highly processed foods. Sugar sweetened beverages is a big deal. But I do think so. There's a dietary part there. I actually, it was interesting. There's a chef who lives out in Souk. He's called the Nature Chef, I believe. We had went a couple years ago. We had my wife and Jesse and his wife and a couple of our friends. We actually went and spent a day with him, and we were doing foraging, and he was showing us all the foods you can eat off the land, right? And just the natural land, like the plants and mushrooms, all sorts of foraging, right? And even animal sources of protein, all that. And when I asked him, and it was like he was basically saying, you don't even have to go to a grocery store. Like with his knowledge base, you could actually live and get all your nutrients without ever stepping foot in a grocery. And when I asked him, like, where did you get all this knowledge? And all the knowledge was indigenous knowledge. All of it was indigenous. So I really do think like the indigenous peoples, the indigenous communities, they actually have like the if we can help them, or they help, we facilitate continuing connection with that indigenous knowledge of living off the land, with their traditional practices, with traditional diets, not and actually really focusing on their traditional diet, rejecting this modern Western standard American diet that has been imposed. That'll actually work a long way to help them with dealing with their diabetes, and the insulin resistance sort of epidemic that we're seeing amongst those communities, right? The other part of it is there is significant research that comes and that's been shown with intergenerational trauma, right? And so, for example, Dr. Elizabeth Blackburn, she was a leading researcher in telomeres, and she was actually a Nobel Prize winning researcher. She wrote the book called The Telomere Effect. And I saw a presentation with her, like when parents have trauma that they've sustained, emotional trauma, and if it hasn't been processed through counseling or through other means before they have children, the children are usually born with lower with smaller telomeres, and it's been shown to have those children also been shown to have a high propensity for obesity and cardiometabolic disease, right? And so when we look at the indigenous communities of Canada, we also have to address the trauma that they've gone through, and really support all of that, in trying to, if cardiometabolic disease, that's like our angle that we look at. We can't ignore, where they're what intergenerational traumas that's happened. And it's actually, if we can address all those, support them, I think they could be the role models for health, and we have to learn from them.
Yeah, no, and what you're saying is absolutely frightening, not surprising, but just terrifying to me.
Mm.
But just to reassure you, this is a particular focus of this podcast series, and we will be doing a lot more podcast interviews with Indigenous representatives to hear exactly the kind of thing that you're mentioning here. So no, thank you for that. That's eye-opening. So I think just to wrap up, Jasdeep, I'm going to have just two final questions for you. The first one is really easy, just for you and your family. What's a typical daily diet? What are you going to eat today or tomorrow?
Like so, so my typical, because I'm not a big breakfast guy, right? So, it depends. When I work virtually from home, I actually will have a bowl of oatmeal, right? You cooked in water. I add in a couple of tablespoons of ground flaxseed, a couple tablespoons of natural peanut butter. Usually it's 3 tablespoons of hemp, right? This is where I get all my protein, Charles, right? I get my hemp. And then I usually add half a cup of blueberries on top of that, and that's like my breakfast at home. Days I'm in the clinic and the office, I just go. I get my wife makes me a chia pudding, and so that's homemade chia. And so it's chia with homemade almond milk, a bit of saffron, a bit of cinnamon, and cardamom, and I take that to go. And then lunch is usually it's usually a rotation of either some lentils or beans, either tofu or tempeh. Those are like one of my favorites, and then usually just greens, right? I don't do a lot of grain. I don't do a lot of grains. For what I found for myself personally is that when I eat more grains, my body reacts differently, and so when I was trying to like maintain my weight, I found that just having the grains in the morning, having for supper, but not necessarily for lunch. So, just really focusing on the legumes and the greens, right, for lunchtime, that works really well for me. But again, it's not the same for everybody, right? And then suppers again, just another. It's basically, it really looks like our dinner looks pretty much like the Canada Food Guide plate, which is like half a plate of vegetables at least, right? Probably more than that, and then whatever our protein source is going to be, and that could be lentils and beans or chickpeas. Um, we do like our lentil pasta. Red lentil pasta is an easy way of getting your pasta fix, getting high fiber and getting some protein in at the same time. Going from there. Right.
Right. That's very interesting. Yeah. But I think listening to you, I mean, we've covered so much ground today. We've covered a lot of ground. But for me, I think the abiding message, the thing that just permeates everything you're saying is the notion of self-kindness and of focusing on your own inner strengths. And that's what you're not trying to enforce anything on your patients. You're trying to build them from within
Yeah.
using the tool of self-kindness. Am I correct in thinking that's just foundational for you?
Yeah, it is. And I have to admit, it hasn't always been that way, right? It's been a
Okay.
learning thing for me, right? So when I first started, I got so excited about lifestyle. I was like, oh, these diets work and this works. And so patients would be referred. I'm like, okay, you got to go do this, 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 and this. And I got one or two responses. I had patients who were excited about that, who were looking for physicians to talk about this. And they were so excited. They're like, okay, I'm going to run with this. And then I had another reaction would be like, who are you to tell me what to do? You don't know anything about me. You haven't taken the time out to learn about me and have colorful language for me in that way, right? And so we would just and then so learning from them and one of my biggest mentors in lifestyle medicine, Dr. Beth Frady, she's out at Harvard. She's a physiatrist at Harvard. She's a former president of the American College of Lifestyle Medicine. She wrote a book called the Lifestyle Medicine Handbook. And I happened to pick it up in I think 2017 or 2018. And she really talks about in lifestyle medicine or dietary changes, you doctors have to learn to take off their health expert hat or turban and really put on the health coaching hat or turban, right? And health coaching is so different than what we've been taught in medical school, right? It's asking, being really open-ended, asking a lot of questions, being limitless curiosity about your patient and not and it doesn't really it doesn't really tell patients what to do. It's actually like finding out what the answers that they're going to come up with. And when I first read this, I didn't believe this. I was like, this is the most ridiculous thing I've ever read. Does not work. But when you're trying to at the same time optimize your clinical practice and you're trying to say, okay, well, I've got patients who are saying Jazz knows what he's talking about, and I have patients saying Jazz is crazy. I've got to also communicate with everybody because sometimes the easy road is to say, oh, this person is pre-contemplated, we move on with our lives, right? And so I started actually trying out what Beth wrote in her book. And I was like, it was like magic. Like the interaction started changing. The energy in the room started changing. Like, it was like patients who, were quite closed, opening their, the crossed arms open up again, right? And you start having conversation. And so it's been through years of just training and working and just seeing patients and then putting these things into practice where I find that that's where I've been kind of led to now. And I do tell patients, I tell patients I have one rule in the clinic, right? Like, and the rule is, I tell patients, after our first conversation, like after our visits, if you go and you do 100% of the suggestions, that's amazing. If you go do 10% of the suggestions, that's amazing. If you just come back, that's amazing. The only thing I'm really not going to encourage in our meetings is negative self-talk, right? Because, and I will say, the world does a great job of making everybody feel bad. We don't need the world doesn't need our help, right?
Well, that is a wonderful phrase on which to conclude this, Joe's. It's been so inspiring, just gaining your insights and hearing of such a wonderful way, different from the way I've been eating, different from what I've been practicing. But that's the beauty of it, that we bring these things together and we find common ground, and all for the obviously for the best interests for our patient, our clientele. But
Yeah.
truly inspiring speaking with you. I just really want to thank you once again for joining us here, Jazz. I'd like to thank Ann Mullins, our producer, Graham Wheeler, our technical whiz, IPTN, the Institute for Personalized Therapeutic Nutrition, for sponsoring this series, and the Rural Coordination Center of BC for inspiring me personally to try to do this work. But Jazz, thank you again. It's been an absolute delight having you with us on At the Helm.
Awesome. Thank you. You're very welcome. And thank you for having me and giving me this opportunity. And thank you to Anne and Graham and IPTN as well as Charles yourself. It's been fun. It's been a great conversation. I feel like we could talk for hours. There's
We
lots to
could,
talk about. There's lots of
we
good
could.
stuff. Yeah. But I love the work
Yeah,
that IPTN does. And a few years ago, I had an opportunity to work with IPTN on one of the diabetes conferences. And really, Sean, really deserves a lot of credit for moving a lot of things forward in the diabetes world in Canada. And it's a remarkable effort. It's a remarkable lift. And I love the dedication on the team is amazing, right? And
Yeah, and so I just mentioned when Jazz mentions Sean, he's talking about Sean McKelvey, who's the executive director of IPTN, who does, as you've said, Jazz does wonderful work. But yeah, no, I'd just like to thank you again for joining us. For our listeners, I hope you've enjoyed this particular podcast, and I really look forward to seeing you again soon on At the Helm. Thank you.
Take care.